I'm honored to present to you Dr. Veterinary Anette Graf, who chairs the Welfare Working Group of the Federation of European Equine Veterinary Associations. Thank you very much for joining us here in Paris, all the way from Sweden, to present to us osteoarthritis of the neck.
Thank you, Eva. Yes. Yeah. Okay. Good. Hey. Well, thanks a lot for having me here. I've had 2 really interesting days, learning a lot from Eva and the rest of the team. Spent 2 days with Crispin as well, looking at the way he works with the camera. It's been eye-opening, and also I keep telling myself I didn't realize it was this bad. So I just thought I'll say a few things more about me than being part of FIVA, because that's going to affect why I picked this topic. I worked for more than 25 years as an equine vet in Sweden, but nowadays I don't work clinically anymore, or very little. I'm actually going in to do a heart ultrasound on Tuesday, but normally I just work with I work with an insurance company called Agria. So I help the claims insurance to look at different claims. It could be for life insurance, loss of use claims, but most of the time it's the veterinary care and fees that we're going to pay out. So it's one of the best jobs I've ever had, because I get to read so many different clinical records of vets, equine vets throughout Sweden, but even we've got Swedish horses outside Sweden as well. So I see a lot of trends, what's happening within the veterinary medicine. So that's why I actually picked this topic. I'm also an amateur dressage rider. I hope it's not too much of a hyperflexion on that picture. But most of the time I spent doing lameness workups and investigating poor performance in both sport but also leisure horses. And I've done a lot of ultrasounding, diagnostic ultrasounding. I always worked with, not always, but for the last 5 years I worked in practice, I worked very closely with my physiotherapist, Pernilla Stenfeldt. And that was really also an eye-opening, how we can help each other to get the horses back into work. So some of the statistics from Agria, we see more than 50% of the claims that we have are due to lame horses. I would say that this is probably one of the biggest welfare issues we have to keep. We use our horses in a way that they actually go lame. The top 3 claims you see are lameness by far, and then it's colic and wounds. And most of these are man-made problems. The way we keep horses, the way we feed them, and so on. A lot of this could be avoided, I think. The majority of the lameness are associated with joint inflammation of the limbs, but also we see tendon and ligament injuries. We also see multiple joints that are being treated and horses coming back for the same problem. So we sort of draw a conclusion this is related to the way we use them. It's wear and tear that causes the horses to go lame. But we increasingly also seen neck and back pain problems. Back problems have been for a little while, but I think the neck has really started coming along, and particularly osteoarthritis of the neck. And my feeling is, well, I see the numbers actually more dressage horses, and also see younger horses. We're talking 4, 5, 6-year-olds, not the old horses getting osteoarthritis. And this is sort of worrying me a lot. And it's particularly, and this is what I'm going to focus on, I'm going to take, we were looking at the whole picture of the horse, but now I'm going to take it out, look at the neck itself, but also I'm going to look at the caudal part of the neck and not the whole neck, and I'm going to look at the skeleton of where we see the osteoarthritis. So it's not like I don't think the other things are not important, it's just that I'm sort of limit myself to this speak. When it comes to loss of use, I asked one of the claim experts to pull out some statistics, and it's the same here. More when it comes to loss of use and horses being put to sleep to get the life insurance paid out, more than 50% due to lame horses. And osteoarthritis of the neck is only 2.5%, but it's still 190 horses from the period of 2018 and last year. And the range from the age of 1 to 24 with an average age of 10. And you can imagine the 1-year-old is probably someone that's had a congenital problem or something, or a trauma. It used to be, when it came to neck problems, it used to be ataxia, the old wobbler syndrome. But what we see more now is that we have sometimes really dramatic behavior changes, aggressive horses, and some subtle behavioral changes as well, which makes it very difficult. And also associated front limb lamenesses or stiffness, stumbling. So there are quite a lot of new research coming around about osteoarthritis. So it's not just the inflammation of the joint itself with the soft tissue. It also got one bony involvement, and that's what is called osteoarthritis. It's usually low-grade progressive inflammation. So you have the inflammation of the synovial lining that will then release inflammatory mediators into the joint fluid. And that is sort of detrimental to also breakdown of the cartilage and the underlying bone, the subchondral bone. And you can see microfractures, bone edema, and so on. Usually this is typically it's a slow and progressive disease, and is used to do either very high loads or very frequent, repetitive, excessive loads on the joints, and causes those degenerative changes of both the soft tissue and the skeleton. So the early stage, we see a low grade of inflammation involves synovitis, so inflammation of the joint fluids and the synovial lining, and capsulitis, inflammation of the capsule, a joint capsule, will lead to inflammation and pain. And the later stage, we start seeing changes on radiographs and so on. We see changes on the bone, and we have substantial loss of joint cartilage. And joint cartilage, the articular cartilage, is a very, very smooth type of structure. So when it gets damaged and it's being replaced by scarring, it's never going to be the same as the original. It's never going to be. It doesn't mean that the horse can't come back into work, but it's going to be much worse off. And with new diagnostic methods, we can also see more of subchondral bone edema and that sort of thing. That's also it's causing a lot of pain. And you then go into chronic pain, and you have scarring, so you will have a reduced range of motion in those joints as well. So the body's not working properly. Intra-articular treatment, this is like a big industry within the horse industry. Everyone is hunting for the latest product that will keep those horses well. The imagination's got no limits what we can actually make to put into those joints. Classically, it's been corticosteroids and hyaluronic acid. Nowadays, there are stem cells available as medical products as well, and also various types of bio-regenerative products that we actually take the bloods from the horse and make serums out of it, so we put back into the joints. Just a few examples there. There are lots of other products available. But none of these are actually treating the disease itself. So the breakdown will continue, particularly if you don't actually rest the horse and recover it and rehab it and retrain it. But in the future, you might have disease-modifying medicines that we can use. But really, what we have nowadays is that we take away the symptoms. We don't actually treat the disease itself. So you're making the horse so it goes down, but you still have the osteoarthritis present. So that's why it's so important those horses get enough time to heal, and that you also rehab them, retrain them. And I think this is one thing that I get upset when I read the clinical notes, that you might have go into rehab, but then they just go back to what they used to do. And that's what actually caused the problem in the first place. And obviously, prevention is better than cure. So can we find a way to train our horses not to get there? That would be the optimal solution. I'm not going to go into details of the anatomy because we don't have time to that. I'm just going to mention a couple of anatomical structures that I will have in my sort of a summary at the end. So we look at the soft tissue. We have the nuchal ligament and the funicular part. That's a very elastic part that starts from the back of the skull and goes all the way to the first thoracic vertebrae. So it's got a funicular part that's very elastic, but then it's also got supportive laminar parts. And this is interesting because in the old textbooks, those lamina were being actually drawn on each single vertebra, but we found out now that they actually stop at the level of C4, the number C4. There's sort of been a lot of dissection going on. We're looking at stabilizing muscles, like the longus collis, multifidus muscles, and I'm just going to mention splenius muscle here as well, because I'll talk about it a bit later. And there are, I was going to put et cetera, because there are obviously lots of other muscles, small muscles and big muscles around the neck. But the nuchal ligament is very important for storing energy for horses. The whole body of the horse is just a mechanism storing energy. And I guess that's why we're starting using those as athletic animals, because they are, they're built in a way that they actually are they're perfect athletes, much better than us. Recent studies as well with fascia is very exciting. I think the myofascial fascial linings that's we've seen in people, but they've also now been discovered in horses, and they do respond a lot to stress, where there will be a constrictment of the fascia when there are lots of adrenaline and tension going on. And of course we have the nerves. We have the spinal cord within the skeleton, and then we have nerve roots and ganglia coming out, going into the peripheral nerves that can be damaged or pinched. But the skeleton, this is what I'm going to come down to, where we have the 7 vertebrae from C1 to C7, and also I included the first thoracic vertebra, because we do see a lot of problems at the caudal part of the neck. So the cervical spine, the skeletal part of it, and this is the articular processes joints that I'm going to be talking about. You might have heard them as facet joints as well. And they contain synovial fluids. So if coming back to my osteoarthritis, this is where we find the osteoarthritis. You got the spinal canal containing the spinal cord and all the nerves there. And they'll have the intervertebral foramen where the nerves are actually coming out from the spinal cord. And then we have lots of different processes where they act as muscle attachments. And we got the body itself for the vertebrae, and then we have the bottom part where you actually have, I'm going to show you a picture in a minute, the intervertebral articulation, which also is to support the stiffening with lots of ligaments. So let's see if I can get my pointer to work now. This is the top of the go out towards the head, and the first 2 vertebrae they look completely different to the rest of them. So I've on purpose excluded them here because we're going to go down the neck, and this is the articular process, and this is the joint itself. So it's the way they are joined together. So you have see that's the C3 and C4. So the number 3 cervical vertebra is joined to the 4th one by this articular process. And then at the bottom part here, you have the intervertebral conjunction as well, and the spinal canal going inside all this. So these are the areas I'm looking for. So there's one joint on each side. This is another one, and we're coming down here, and all the way down here. And as you can see, those articular processes, they do become enlarged as you come down. That's a sort of normal thing, but it's also the first sign of osteoarthritis, which makes it a bit complicated when we making diagnosis. So 2 joints, one on each side. There's a fibrous capsule that includes this. So we've got it's a cartilage, and then it's got the fibrous fibrous capsule around it, and then the multifidus muscles, one of the stabilizing muscles. So there are several bundles of them, but they actually fuse into this fibrous capsule, and you have about 3 mils of synovial fluids in those joints. And that's another problem when we are using ultrasound, is that you should have some fluids there, but just to assess whether they have increased volume of fluid or not, that can sometimes be difficult. At the bottom there, we have an example of a lateral radiograph of the 6th vertebra and the 7th vertebra, and when they're joined together. So this is what it looks like when you take radiographs of those articular process joints. Now, like I said, what I find when I read the clinical notes, most of the horses been treated in the neck, and even for loss of use cases, there are a change between C6 and C7, so the 6th and the 7th vertebra, and the 7th and the 1st thoracic vertebra. You see sometimes when you look at studies, then they see changes as well around C2, C3, and then at the caudal parts, so from the 5th vertebra down to the 1st thoracic vertebra. And again, the most common reason is a low-grade inflammation, progressive disease due to overload and repetitive microtrauma. But there are other causes, and I'm not going to include them in this because there are some horses they got developmental disease like osteochondrosis or congenital or malformation, and these are the ones that are. The first one here is one that's is getting problems with the ataxia and the wobbly syndrome. And the other one is quite a new one, the equine complex vertebral malformation. That they have discovered changes of the 6th vertebra and some in lots of different breeds actually, and they sometimes have very, very subtle clinical signs. So I'm not going to go into those because that's a completely different disease. But they sometimes get osteoarthritis as a secondary problem. This is just an example where you have some fractures or some microfractures within the spinal canal. So when you see an X-ray like this, we have this is not a perfect one, it's a bit rotated, but you have the articular process joints there, and you can see the other one on the other side there, and then you have the intervertebral foramen, where the nerve's coming out, and you have the spinal canal going down here. And of course, you can have very acute trauma. You have horses falling. You have young horses playing and rearing up and tipping over and that sort of thing. So you obviously not all of them are due to a low-grade progressive disease. So it can be started off by acute trauma as well, but that's not the normal case. But the clinical signs, and this is where it is becoming quite difficult. I just have to move around so I can see you. There are some that are specific signs to the neck. For instance, where you have to do very, very careful and thorough palpation. This is difficult. It takes a lot of skills to do this, to pick up, but also to interpret it, what you actually feel. So you can have muscle spasm. We were talking about some horses having overdeveloped muscles or underdeveloped muscles. And that's the sort of thing that you have to look at. You see stiffness or even resistance to both bending, but also dorsal-ventral, so flexion and extension of the neck. But again, there is a natural resistance in the horse's neck, and that's very individual. So that's also something that takes a lot of skill to be able to evaluate. I said muscle atrophy. Sometimes it's overdeveloped, and sometimes you more or less lost some muscle mass. And of course, even with those horses with osteoarthritis, with old horses, and you have impingement on the nerve or even in the spinal, narrowing on the spinal canal, you will have ataxia and dysmetry, etc. as well. Also, some horses, they can have their neck in the lock position. I don't know whether you've seen that or heard it, when they usually it's a low position, and they usually unlocks themselves. And it's a bit, I don't think we know exactly the mechanism behind that. But they usually get their neck X-rayed, and you quite often see findings at the caudal part of the neck. But what I find it's difficult is a lot of these horses, they have non-specific to the neck. It's more the whole body. You have a drop of the thoracic sling, so the stance is not optimal. You have forelimb or lameness and other gait abnormalities in the front leg, stumbling. And as you know, these are a lot of things other things that can cause those clinical signs. Also generalized undeveloped muscles, so the top line syndrome, for instance. But the behavioral problem, I think, is one of the most difficult part because they might be quite bad behavior, or not bad behavior is probably the wrong word, but they have problems riding the horse. So sometimes they're really scared of the horses. And is this due because you have some X-ray findings? And it becomes difficult. But you can have head tossing, teeth grinding. It's just an uncomfortable horse, really. So it could be caused by anything. And also what I find is that we have some really subtle changes. A lot of people have riding problems with their horses, behavioral problems, or at least the horse might have problems with their owners. I think probably the other way around. But this is what I see a lot. So it's subtle changes and behavioral changes. So the diagnostic methods that we have today, because you might think, oh, is the increased number of horses with neck problems, is that increasing because the vets are making the diagnosis? We have more diagnostic methods, could be one reason. And then we started looking at the necks, we have findings. So radiography is the most common one. And the first thing that we usually see or comment on is the enlargement of those articular processes. And like I said, some horses have larger articular processes, and they will also increase as we come down the neck. So the C6, C7 would have a larger articular process than between C3, C4, for instance. But we can see remodeling and fragmentation. Nowadays, we quite often use ultrasound as well. Again, we can see osteophyte or enthesiophytes. That's when you have calcification where the muscle attaches to the bone. And we see synovitis and also capsulitis. And these are the signs of osteoarthritis. Scintigraphy is also used where we can see bone phase activity. I'm just going to show you a couple of slides on this. And I think the one that we can see best details at the moment is the computed tomography, CT. And you can use contrast as well on both the plain radiography, which is not done that much anymore because this CT is sort of superior to it. But the majority of horses actually, when you examine or investigate pain in the neck, it's using radiographs. In future, hopefully, we can use magnetic resonance imaging, and then we can start looking at nerve and nerve roots and that sort of thing. We can't see that today, and that's what they use in people. They use MRI. I spoke to a doctor once and said, "Why do you use CT?" And I said, "Because the horses are weighing 600 kilos, and we have problems getting their heads into the magnetic camera." I'm not going to dwell on the treatments, but you use sort of the same intra-articular treatments like we do with all the other osteoarthritis, particularly corticosteroids and some of these bioregenerative products as well, and general painkillers like non-steroidal anti-inflammatory drugs, and then other types of pain management. You see a lot of shockwave treatment or acupuncture. But then again, the rehab is the most important thing here to get those the horses back into shape again, and also specific exercises and retraining. I think this is the big challenge to get people to understand that they can't use the horse the same way as they used before, because they're just going to be coming back. And that is what I see it happens. They come back and be retreated. But radiography, what you can see on this one, you see the articular process, and you see a little blob down here. It shouldn't be there. This is not that enlarged enlarged. This is just a small change. This doesn't say that the horse got pain here. It's just say it's got a radiographic change. So we go have a little bit more severe type of enlargement, and even some occlusion of this intervertebral foramen. So you might start thinking, if you have clinical signs, even neurological signs, then you might think that this is the reason for it. Another one that's even worse, and then the one that's really clear, have lots of changes around that. The problem is this is just one way, one direction, and we know that we have to work our way around the spine. So if you don't get those pictures correct, if they're not complete straight laterals, and it's very, very difficult to do that, then it's going to be very difficult to interpret the shape and the size of these articular processes. So that's why sometimes this is over diagnosed, and some horses you know, you can't just take X-rays and then say that the horse got osteoarthritis and it's no news if it's got no clinical signs of a problem. And that's why a lot of veterinary associations now gone out to say, do not X-ray horses for pre-purchase examination. Do not X-ray the necks because it doesn't tell you anything of the use of the horse. So that's a big limitation of using radiographs. It's difficult to get them right, and it's also very easy to over-interpret what you see. So what you can do, not just taking that lateral like this, you can also do, I'm probably not showing up very well, but you can do obliques, so you can take more angles, so you can get a little bit more information. And you can add ultrasound to it. Again, ultrasound is only as good as the person holding on to the probe. Because it is a live type of examination. Again, very easy to overinterpret. But you can see on this one, we can see a little bit of fluid collecting. You can see a little bit of could be an esthesiophyte. I think that's what the Ellen Law that gave me the picture. They said there was an esthesiophyte there. But it's just, you have the joint coming down here. You see, this is very difficult to see because this is just one still picture of a whole examination. But this is also what you use when you inject those joints. So you do that ultrasound guidance that you know that you're in the right place. So this could add information. But again, if you don't have clinical signs of pain in this area and you just ultrasound and say, oh, it's a little bit more fluids in there, then it's not the same as saying that the horse has got osteoarthritis. So you have to be careful. Scintigraphy, it will show up the activity in the skeleton. So it's quite a blunt method, but it could help sometimes. So these are actually the same horse as we had on those pictures, on the X-ray pictures. The problem here is because we see most things at the caudal part of the spine, this is where the articular processes are larger. So there's a risk that they will actually have an increased activity. So again, you have to interpret this very carefully. So we come to the CT, and this is when we can see things from different angles, particularly when you do contrast studies as well. You can see particular compressions on the spinal cord in all directions. But again, so this one here, this is the intra-articular joints, quite nicely. And this one here has got a regular outline there. So it's got a start of osteoarthritis. But even here, we get lots of information, but doesn't say anything about presence of pain. So again, gives us information, but doesn't necessarily tell us the whole story. So we have a lot of challenges when it comes to osteoarthritis of the neck. The clinical symptoms, there are quite often other problems present at the same time. You might have kissing spines or back pain. There might be a lameness present, and there might be behavioral problems that might be caused by anything. The clinical examination is also very challenging. It's very subjective, and you need to be very skilled. I usually use my physiotherapist, Pernilla Stenfeldt, to have a go first. So if I didn't feel anything, I would always give her a chance, and she will always pick up on things that I never picked up on. And the same range of motion. It varies from horse to horse. You have to take that into consideration. Even assessing conflict behavior is difficult. Is it actually a problem with the owner and the training that's gone bad? And also, are there other orthopedic problems? So it's very important to rule other things out rather than just jump to the neck and say, oh, it's got a neck problem. We have the limitations of those diagnostic techniques. And maybe CT is the gold standard until we have MR, but maybe we have that in the future. And the interpretation of those diagnostic images that we have, are they of clinical significance or not? And the risk of over and even under interpretate those. And then we have a challenge when it comes to treatment and prevention. And the rider's compliance. Are they willing to do the rehab exercises? Are they willing to think about retraining and do things in a different way? Because that's going to make all the difference if you can get this horse back into shape. So this is the question that Eva said to me. Can you say that hyperflexion is the cause of osteoarthritis? We know about, yes, we mentioned some of these already this morning. The short-term effects, we've seen so many research. It impairs vision, affects the balance, definitely affects the airways. We saw that horse the other day or yesterday. We also seen in lots of studies with the increase of conflict behavior and stress, and that's going to put tension on the fascia. And if you do that over a prolonged period of time, you might get scarring and the fact that the horse can't actually use his body in the correct way. We also seen, they also measure the increased pressure of the nuchal ligament over the, particularly the C2 region. You can have like 4 times the normal load. And we also know that it loads the lamella part of the nuchal ligament unevenly, depending on whether the neck is extended or flexed, and then the head also being flexed in the wrong position. But it's got other effects. I know our last meeting you were talking about the top line syndrome, but you might wonder why I got a teapot there. But that's actually my physiotherapist's expression of the teapot frame, and this is her drawing, where it's not the arrow of force; it's just the way things are going when the horse is had that shortened neck, and the dip of the back, and the tip of the pelvis, and even the thoracic sling coming down. You have the effect on the longus collis muscle. That's a very stabilizing muscle, and let's see if I missed something. Yeah, and also there have been some studies where you see normally splenius being a stabilizing muscle, and in hyperflexion that will actually have a reduced muscle tone. And the brachiocephalicus, that's the one that's coming on the down part and actually attaches to the front limb, and that might be one of the cause of front limb lamenesses or irregularities in gait with horses having neck pain, is that becomes overactive. So I don't think problems in this region of C6 to C7 and T1, that happens for a reason, and I think they haven't got the same stabilizing mechanism there by nature, and then we make it even more difficult by having the horse in hyperflexion. So the long-term effects then of hyperflexion, this is when it becomes difficult or even impossible to prove, and we discussed this the other day, because just because you have osteoarthritis, swap the letters there, even if you have the fineness, it does not mean that it's pain, that it's painful. And even if it might have been painful, but it might not be painful anymore, you can if you train the horse properly. And if there is presence of pain, it's not always related to osteoarthritis. So just my last slide. Why have I done that? I swapped the letters, sorry about that. Osteoarthritis, I must have been tired when I did it. Of the articular process joints, is only one of the causes of pain in the neck for horses. And the presence of it, when you have radiographic changes, doesn't always mean pain. And it's often combined with other problems. And the diagnosis of it is very, very challenging for the vets. But what I have found is I found no evidence that hyperflexion to be beneficial. But when I gave some similar talk to a couple of riding instructors, there was something, but you're wrong, Annette, it is beneficial. I said, how do you mean? Yeah, but you get higher grades, higher scoring at competitions. So I added this. So I haven't seen that it's been beneficial for the horse. So thank you.
Thank you very much, Annette. Thank you. Thank you very much. So we have 3 minutes in advance. So I just wanted to ask you, Annette, if in Sweden, in the vet school, do the students now learn things about top-line syndrome and negative effects of hyperflexion? Still not.
Not that I'm not aware of that. Sorry. I'm not aware of that anyway. No.
Because we never learned these things when we were in school. So it's a problem that vets are not aware of this kind of problems.